I'll be talking about a project I did through a Fogarty Fellowship, and want to start by acknowledging the CFAR for the past and ongoing support I've received, and also NIH and Fogarty. This fellowship was funded by the Office of Behavioral and Social Sciences Research, OBSSR, at NIH. So I was in Tanzania for the past year, from July to March, and just started in a new faculty role at the school with a secondary appointment at DGHI. We'll be talking about three separate small projects today. The first was a systematic review and meta-analysis of pregnant and postpartum women living with HIV in Tanzania. The second was a cohort of 200 women enrolled during pregnancy and followed to 6 months postpartum, and their outcomes, including depression and anxiety. And finally, the Fogarty Fellowship, which we conducted with community health workers in Moshi, Tanzania, over the past year. And this was all adults living with HIV. So the first two studies focused on pregnant and postpartum women. The third study was with all adults living with HIV. On the bottom left, you'll see my research team in Tanzania. That's Lisa Wanda and Ismail Amiri, who are joining us from Tanzania today, and we're really excited. One of the advantages of a virtual conference is that these folks were able to join us from Tanzania, so it's great to know that they're here as well. So a little bit of a primer on HIV care in Tanzania. The adult prevalence of HIV is 4.8%, approximately around at this time. Testing and ongoing care is provided free of charge at small community clinics. So they've done a good job of decentralizing HIV care to a lot of small community clinics. And the care typically involves an initiation of care and then monthly clinic visits with a brief nurse visit and prescription renewal each month. As a psychologist, I'm also very interested in the mental health treatment available to folks living with HIV. And while the coverage for HIV care is quite good these days, the mental health care in the Kilimanjaro where we were working was quite a bit lower. So there's currently one psychiatrist and one master's level counselor working at KCMC, which is the main referral hospital in the region with a catchment area of 1.8 million people. So very little coverage at the central hospital. There is a small inpatient psychiatric unit at the local public hospital, Mwenzi, that's staffed mostly by mental health nurses and medical residents. There are also a few counselors operating locally with varying levels of formal training in mental health. And so when I was there, I was the only PhD level psychologist that I was aware of working in Moshi at the time. So now to the systematic review and meta-analysis of our studies in Africa. So we found 22 studies that had been conducted in Africa describing rates of in HIV care among pregnant and postpartum women. And we found that 73 to 76% of women were retained in HIV care 6 months after enrollment. So remarkably low and even lower than general adult populations of people living with HIV. We were also kind of surprised to find that many of these studies didn't do, they enrolled people, a week or two after they had been diagnosed. And so they were missing people who maybe were diagnosed and then never came to their first appointment. So there was this steep drop off in retention right at diagnosis, and another drop off around the time of childbirth, but that wasn't very well measured either. So although the time of childbirth was a really key point for retention among many women, studies were kind of measuring retention from the time of initiation of care with little regard for the time of childbirth, which of course doesn't make a lot of sense. So a lot of women initiate HIV care in order to try to not transmit HIV to their children, to the baby. And so that once they have the baby gets tested, maybe tests positive, and now the woman is discouraged and drops out of care for herself. Or maybe the baby tests negative and she kind of thinks, job done, now I can drop out of care and don't have to inconvenience myself with these monthly clinic visits because the baby's safe. When in fact, we know that a lot of babies actually end up contracting HIV through breastfeeding. And so if the mother stops taking her ART at childbirth, she's placing the baby at risk. So really important to kind of keep women engaged throughout childbirth and the postpartum period. And also, of course, for their long-term health. We also found 25 studies describing factors associated with retention and care, and found risk factors including younger age at initiation, those who initiated on the same day of their diagnosis, those who initiated later in pregnancy, stigma, HIV stigma, and, those who are experiencing challenges, and those who had low social support. So seeing this kind of confluence of demographic variables, but also social challenges that contribute to lower retention and care among a lot of women in the pregnancy and postpartum period. We then conducted an R21 study. This was led by Drs. Melissa Watt and Blandina Mbaga, and 200 pregnant women living with HIV, and followed them through 6 months postpartum. We saw 79% care retention in this population, which is slightly higher than what we had seen in other studies in Africa, but still not optimal. And remarkably, 25% of these women met criteria for likely depression, 24% for anxiety, more than a third had experienced violence in their lifetime, and nearly 13% were experiencing suicidal ideation at enrollment. Although I guess the positive part of that was that had reduced substantially to 4% by 6 months postpartum. So what we saw was this incredible burden of mental health challenges and quite a bit of overlap between these conditions, as well as stigma, disclosure challenges, and low social support. So a lot of women who were experiencing one of these challenges were actually experiencing multiple. So kind of supporting that view of HIV where risk factors are very shared and tend to overlap. In talking to these women, gaining qualitative perspectives, they described their care and their nurses as generally supportive, but also kind of overburdened. And so a lot of times, the content of their counseling, their HIV counseling in their appointments was focused on education and some brief reassurance. So we called this, we named this manuscript, "She Just Told Me Not to Cry." Because it was kind of brief reassurance and warm, but not really depth. There wasn't a lot of depth to that counseling. They found that there was little follow-up provided for emotional distress. And so these women were often going back to their communities, to their home, to their families, and trying to find more informal forms of social support that weren't being met in the community setting. When asked why they felt this was that was the way it was this way, patients often said nurses seemed overwhelmed or hurried because of their high patient load, and just may not have had the time to sit down and provide a lot of counseling to them. So this is where we bring in the idea of task shifting in community health workers. We know that the nurses are really overburdened in this setting, and task shifting that's been around for quite a long time. We've seen community health workers from the 70s and 80s and before, but it's seen a bit of a resurgence in the last 10 to 15 years as we see people from the communities being recruited to support healthcare professionals. So these people have lower levels of training, often in this setting, that's a secondary or high school education. And they're being taught given some basic training in HIV care and retention topics, and then asked to kind of provide that support to the patients to support the nurses. In Tanzania, there's a nationwide cohort of community health workers. This is known as home-based care or community-based HIV services. You'll hear me call it the CBHS program. It started in 2005 and is really intended for these community health workers to support HIV care engagement and retention in all of these small clinics in Tanzania. So most clinics have a cohort of 5 to 15 community health workers who are supporting HIV care in that setting. As it's intended, this program, they're supposed to be connected with people at initiation of care, the first appointment, and follow them regularly after that. But we knew that the program had not been formally evaluated, so we were really interested to see this is how it was actually working in practice. In the Kilimanjaro region, the CFAR program is operated by the Elizabeth Glaser Pediatric AIDS Foundation, or EGPAF, in partnership with the national government. So for this Fogarty study, we did qualitative interviews and clinic observations to learn about the CBHS program. We enrolled a cohort of 80 patients at the initiation of HIV care and followed them for 3 months to understand correlates of their CBHS contacts, so whether the contact they were having with those health workers seemed to be correlated with other outcomes. And then we had planned to hold stakeholder meetings to plan a future intervention. The qualitative interviews included 4 interviews with CBHS leadership, 2 at the clinics, 2 from EGPAF, sorry, and 2 from the local government. We interviewed 8 clinic nurses, 18 of the CBHS workers, the community health workers, and 18 patients, and then had 20 hours of more formal clinic observation, although we were embedded in the clinics in our clinic office, so it was actually quite a lot more than that. We were around to observe a lot of the different care provided and to meet with patients throughout their time in HIV care. So our qualitative findings, the CBHS leaders, those from EGPAF and regional government, felt supportive of the program, but they acknowledged that they were struggling to provide resources to the CBHS workers. They kind of anticipated that the CBHS workers we talked to would describe a lack of support. And so those workers get a stipend of about $20 US per month to support, otherwise they're completely unpaid. So $20 per month. And that's intended to support their transportation costs and cell phone minutes and data plans in order to contact patients by phone. And it just barely covers expenses, if at all. And so most people are doing this truly out of the goodness of their hearts. The CBHS leaders also recognize the need for refresher training because many of these CBHS workers had gotten an initial training, not had a refresher session. So for those who'd been there since the beginning of the program, which was a fair proportion, they had gotten initial training 15 years ago when the program started and no formal training since. The nurses kind of agreed with the patients. They felt that they didn't have appropriate time, especially to track patients who were lost to follow-up and missing appointments, and they did appreciate that CBHS provided a lot of assistance in tracking patients lost to follow-up. But they did perceive a lack of connection and communication. They said sometimes they tried to reach out to the CBHS workers and there was no one on site, even though there should have been a CBHS continually on site to provide in-person collaboration with the nurses. So they just felt that there was a lack of connection. The CBHS workers themselves described the work as personally fulfilling, but emotionally taxing. So it was difficult for them to stories and patients who were really struggling. They also did feel that the small stipend they received was not enough to adequately perform their work. And so this quote here, you can see that, even if you gave me 1 million shillings, if I don't have love for my patients, it won't work. So they really understood that this was care that they weren't being paid for. They were volunteering to provide. And so the care truly came from the goodness of their hearts. In talking to patients, I don't want to steal the thunder. We have a trainee here, Nazwa Mohirwa, who's going to be presenting a poster on the patient perspectives on the CBHS program. A bit of a spoiler, many of them didn't know about the CBHS program at all. They'd never been informed about the program, or they had only met with a CBHS worker once. And so it seemed that the program was more of a way to engage people who were lost to follow-up than to actually be kind of an ongoing connection with folks. So it was much more about re-engaging those lost to follow-up rather than good connection from the start. So we know from the cohort that only 58% of patients had ever heard of the program and only 26% had ever met with a CBHS worker. Age of less than 35 years and depressive symptoms were the only significant predictors of care engagement challenges. And the contact or number and quality of CHW did not impact either care engagement, well-being, or mental health. So the level of contact with a health worker really didn't predict positive or negative outcomes for patients. So to summarize, although there was suboptimal early connection and ongoing care engagement, those who did meet with a CBHS worker quite a bit, those who met more found it to be quite helpful. And so that again, I'd encourage you to look at the poster presentation because you'll find that the qualitative perspective of patients who did have a lot of contact, it was really quite positive. In the cohort, CVHS contact was not correlated with improved care engagement, and there was a lack of refresher training for these community health workers. And finally, they received a monthly stipend of less than $20. All this adds up to something that might seem really discouraging, that the program doesn't work, but I really found it remarkable that the program is still surviving at all. And I think that that means that there's a strong kind of undergirding, there's a strong support underneath that is that actually creates a great opportunity for new training, new support, and capacity building. I think with a little bit of resources, we could really boost this program and create something really remarkable, that it just needs some additional kind of refresher training and support to get it back on track. So I think there's incredible opportunity in terms of mental health. There's evidence from other settings that community health workers can provide really outstanding mental health care. And we're hoping to do similar things with this cohort. I'd like to acknowledge my research team, Lisa, Ismail, Kimberly, and Amnazo at Duke and at KCMC. My mentors on the project, Blandina Mbaga, Michael Ralph, and Melissa Watt. The clinic staff and study participants, the Maisha study team, which is the R21 led by Drs. Watt and Mbaga, the KCMC Duke collaboration, and DGHI for their support of this work, and of course, NIH and CFAR for their outstanding support. And I'm happy to take any questions.
Fantastic, Brandon. Thank you very much. So we probably have time for one question, and then we'll be moving into our break with a plan to return a few minutes before 11 to get started on the next session. But we do see a question here from Sarah Wilson, Dr. Wilson. So Brandon, it seems like there might be significant challenges to fidelity to best practice perinatal mental health care among these outreach workers. Do you have thoughts on how fidelity and barriers to fidelity might be measured in this setting?
Yeah, so the challenge to fidelity is kind of a good manual in place to know what to bring fidelity to. That there was kind of an initial framework introduced, but now the program has really morphed to be something very different. It's not about ongoing engagement and support anymore. It's about just kind of tracking those who are lost to follow up. And so I think the first part is to really document what this program is intended to be so that we have something to aspire to. And I think that really needs to be locally driven. And so we had planned to do stakeholder meetings, but unfortunately with COVID, I had to come back 3 months early. Luckily, we were able to get the data we wanted from the cohort, and thanks to my Tanzania team for carrying that on after I had to come back. But you know, those stakeholder meetings are going to be just crucial to get people on board with kind of developing new standards for the program, and then taking the lead and getting the program back on track.
Thank you, Brandon. So we'll have time for one more question. Last one, this is from Dr. Richwood. So based on the results of your study, Brandon, what are some ideas to provide sustainable mental health services, particularly those that would provide adequate compensation or support for these community health workers?
Yeah, that's the golden question right there, is how do we kind of monetize these programs? And we just don't know. It's not something that's ever really been charged or billed for. And so it's typically something that's provided by charitable organizations, international organizations, or governments, and that continues to be the case. So there's certainly room for some advocacy for the government that they would get some return on investment by supporting these health workers with a little bit more resources. But other than that, you know, I think it's difficult for an external grant. We might be able to provide some temporary funding, but you know, then once that program is over and that funding is withdrawn, is that it actually discouraging people to continue the work. And so we're trying to find kind of more long-term sustainable pay structures to get these people some support to do the work that they're doing, because it's so important.
Great. Thank you so much, Brendan.